All right. So today we're going to talk about pain management. Um, we're going to talk a little bit about this because it's during my time in Tanzania, I did notice that there was a fair amount of difference in care between pain management in Tanzania and pain management in the United States. So I thought I might just provide a little bit of insight about how we do it in the United States, and then you can kind of take that information for whatever it's worth. Um, First off, the case that stuck with me was an open fracture case. An individual who had a right leg deformity and he had exposed bone. He had Gustilo-Anderson type 2 open fracture. He's about 30 years old. Um, the diagnosis was pretty obvious. It was pretty easy to examine him and figure out that he was in significant pain from his leg. The rest of his exam was a little bit difficult. He was atraumatic everywhere else, grossly. But with patients like this, you want to make sure that you expose them and take a look at their entire skin. He was screaming out in pain. It was really difficult to examine him. He was given some diclofenac and he was placed in countertraction. Ortho was consulted. The learning objectives are just to kind of talk a little bit about analgesics and their pharmacology, kind of the indications of each analgesic as relates to mild, moderate to severe pain, and talk a little bit about opiates. We're going to also summarize the difference between analgesia and sedation. And we're going to talk a little bit more about why analgesia is indicated and why there's a good a good amount of evidence to suggest that we should be offering it to everybody that we treat. So first off, in America, it, we do it a little bit differently than you guys do it in Tanzania. I know that there's some degree of asking the patient how severe their pain is. But usually we actually ask the patient to rate their pain on a scale of 1 to 10. Um, the reason why is because it gives us a number to actually come back and assess. And you can easily do that by asking the patient if it's mild, moderate, or severe. It'll always remain a subjective portion of the assessment, but pain allows you to make objective clinical suggestions, and it's a guiding symptom in terms of how to work up a patient. If a patient comes in with chest pain, um, you know, the differential changes depending on whether or not they have epigastric pain on your examination. So um, the the evaluation of pain is a very important one. We treat this mostly, or we teach this mostly in the United States as something called DOTS, stands for deformities, open wounds, tenderness, and swelling. It's usually a helpful term to allow kind of some degree of insight of how to evaluate trauma, but it's not necessarily something that like is applicable to other sources of pain. In the United States, we got in trouble a lot for something that we called the six file sign. Basically, in the United States in the 80s and 90s, there were big pharmacological companies that wanted to create something that called called pain is the sixth vital sign, i.e., everybody gets a pain scale when they go into the emergency department or go into clinic. Um, and that was actually created by big pharmacology to basically promote the use of analgesia, specifically promoting the use of opioids. Um, it was something that we realized was not necessarily a very good idea. Um, and because of it, we were very much more rational about the use of opioids in our patient population. But we also have an opiate crisis that endemically kills hundreds of thousands of people. I forgot to fill in this number, but it's a lot of people, both directly and indirectly every year in the United States just alone. Um, that being said, I do want to talk a little bit about opioids because I know that they're used extremely sparingly in Tanzania. I do think that they have a role for treatment in acute pain, so we're going to talk a little bit more about that. So, acute versus chronic pain. When somebody has acute pain, there's a very specific pathway that gets followed. It's called the nociceptive pathway. It's basically driven specifically by like a very specific neurotransmitter and receptor. Um, the neurotransmitter then ends up setting off a acetylcholine pathway that connects to the brainstem. Um, so the receptor connects to the brainstem, and then once the brainstem actually associates uh, the pain, it creates the spinal reflex, wherein the patient moves away from the pain, or they end up feeling, um, some degree of reflex regarding the actual painful stimulus. So there's a bidirectional pathway already, and then it sends it to the brain to actually correspond what to do with it, and how it creates the patient's emotion, thinking, and conception of the pain. Um, this is specifically in discussion with chronic pain. Acute pain works a little differently. In fact, the spinal stimulus is not present when you have chronic pain at play. It's a much more complicated mechanism, but the most important thing is that when chronic pain is at play, the acute nociceptive signals that we usually see that involve prostaglandins, that involve other types of nociception, aren't necessarily at play. So acute pain should actually be treated quite a bit differently than chronic pain. And it's just because the mechanism is different. It's not necessarily because the pain is any different to the patient. It's more important to understand the mechanism is just different. So acute pain is usually responsible to non-steroidal anti-inflammatories, paracetamol, and medications like opioid if the pains are moderate to severe. Chronic pain usually differs depending on the etiology, and it can be responsive to a number of different other pain medicines above, but it can also be responsive to other things. And we'll talk a little bit more about that. So in the United States, probably the medication that I reach for the most for actual acute pain is acetaminophen. The reason why is because paracetamol does not have any type of contraindications. It's essentially just a very safe medication for almost all people, children and adults. It works indirectly on the COX receptors, and it basically decreases the production of prostaglandins. Its mechanism is actually poorly understood, but it's usually considered as a very like effective and efficacious gold standard medication that we use across care. My dosing for this medication is usually 15 milligrams per kilogram. So patients usually max out at about 60 kilograms. And you can dose it up to 1 gram every 6 hours. There should be dose reductions for patients that have liver dysfunction. Um, and acute overdose syndromes are very, very real. And that's the one thing that's actually the biggest thing to make sure that you deal with this when dosing this medication with patients is to make sure that they're very understanding that 4 grams is the absolute maximum, assuming that they're above 60 kilograms. Um, because anything above that can cause an acute overdose syndrome. And it can create acute liver failure. In the United States, this is actually the most common cause of acute liver failure. It's a very good medication for multiple different etiologies. You can use it in chronic pain. There is some degree of like tachyphylaxis, so some patients feel like they don't get any relief from Tylenol if they use it too frequently. So, in addition to kind of our first line medications, usually we recommend a non-steroidal anti-inflammatory. In the United States, basically includes medications like diclofenac, ibuprofen, Toradol, aspirin. Um, Usually we don't recommend aspirin as an analgesic because it's got a little bit of higher risk of bleeding, and so we've taken advantage of that effect and we use it for stroke and heart disease reduction. These medications actually selectively inhibit the COX receptors. So basically, their mechanism is more direct, and they decrease prostaglandin formation. And we know this from laboratory studies and basically studies on enzymatic pathways. Um, we also know that this actually increases your propagation or possibility of bleeding, as well as also increases your risk of peptic ulcer disease and kidney disease. So these types of medications can definitely be avoided in those people. These medications do have toxic effects that are very real. It's unlike paracetamol. I don't necessarily selectively give this to people depending on what their pain is and how often they might be taking it. Um, Diclofenac, which I know is the medication that you all commonly use in casualty and Tanzania, is usually dosed about 10 mgs per kg, and it can be dosed up to 500 milligrams. So the max dose is 50 kilograms. It's usually a pretty safe medication. It's very efficacious for anti-inflammatory. It's also it's a very potent analgesic. Um, it's usually used in conjunction or kind of competing with ibuprofen in the States. The reason why people pick ibuprofen is it's a slightly weaker NSAID, but it has comparable pain scores, so it's a little bit less of a potent anti-inflammatory. And it's also the best tolerated. It has the least amount of effects when we're talking about the kidneys, the liver. I'm sorry, the kidneys, the stomach, and bleeding risk. Um, and like I said earlier, aspirin we generally avoid as an analgesic because it's a pretty good medication for clot reduction. Let's talk about a little bit about opioids. So in Tanzania, I understand that the opioid that is generally available is morphine. There are many medications that are available, including oxycodone, hydrocodone, hydromorphone, and fentanyl. Fentanyl gets a lot of news in terms of like its misuse. But I will say that it's a pretty potent analgesic, and when used appropriately, it's a pretty helpful medication, especially for the individual that we talked about in the case report. Um, the side effects can absolutely be severe and significant. So usually we want to avoid them for chronic patients. Um, the reason why I bring it up though is because you see a lot of patients that come through casualty and you see a lot of patients who are inpatient who have severe pain. And there's been a lot of studies and data about misuse of these medications. And one-time use in patients who are naive does not necessarily preclude them to a higher possibility of misuse in the future. Um, when used acutely, the big thing that you want to make sure is that you monitor their respiratory status. Now, this can be done through oximetry or this can be done through telemetry. When used chronically, the most common side effects are constipation, nausea, and vomiting, um, as well as, things like tolerance and sedation, stuff that you probably would never see in Tanzania, but stuff that does occur in the United States when these patients are on these medications for a long period of time. So, the reasons that we care about, so this is just a general discussion regarding dosing. Morphine is probably the most important one for you guys to know. It's here for your reference. Usually the IV dosing is slightly different than the PO dosing. And that's just generally because the bioavailability of the medication is quite different. Um, it generally causes itching. That's actually usually because of its propensity to attach to the histamine receptor. Because of that, I usually actually avoid it in the United States. I usually use more synthetic opioids because they don't have this side effect. Not a true allergic reaction. When people say that they're actually allergic to morphine, it's just basically just a adverse effect of the medication, and it's specifically because the medication actually binds to the histamine receptor. Um, I left this blank. I'm sorry. The hydromorphone medication is usually left reserved for like IV cases. It's usually considered a very potent medication. It's used for breakthrough pain in inpatient. Uh, the other option for that is also fentanyl. Oxycodone and hydrocodone are probably the most common oral formulations. And these are both PO generally. Um, And then hydromorphone can be used with both, but it's pretty rare to use with PO. It's more used mostly for like transplant patients who have significant severe pain and fall. And fentanyl can also be given intradermally or subcutaneously, not subcutaneously, intradermally. They make it in a patch, but it's very short acting and it's usually best for acute pain. And the dosing of this medication is 500 to 1 or 550 to 100. So is it important to know that opioids exist? Um, it's important because these medicines are kind of considered a standard of care in terms of treating like very severe pain. These medications carry a risk for abuse for sure. It's really important to have monitoring programs and ways of preventing misuse by prescribing short scripts. But the use in the hospital does not necessarily assume a possibility or susceptibility of misuse later on in life, especially for patients who don't have any prior exposure to opioids. For patients who have what we consider high risk profiles, i.e., they have a history of drug use or they have a history of misuse in the past, this does create a predilection for possible misuse down the road. But being a humanistic doctor, you want to make sure that you treat acute pain that those patients have as well, especially if you think it's legit and they're not necessarily seeking. Um, it's really important to remember that opioids are not indicated in chronic pain. And unfortunately, the United States didn't get the message on this soon enough. It really should be reserved for, post-operative pain, uh, intra-abdominal pain. Abdominal pain is a good reason to use opioids, and then fractures. But this is a high part of our population that we see coming through hospitals and casualty. Um, and pain is a cardinal symptom. It's something that we can treat. As I've heard before in my training, and then the need to treat for pain is this essentially one. All you have to do is give somebody some pain medication. 100% of people will actually get better, depending on the etiology. There are other medications that we use in the United States. This is more just for reference, just to understand that there are a lot of different ways of treating pain. Um, Sometimes when I talk to the registrars or the other consultants that worked at Soviani, um, I found it interesting that they didn't necessarily feel like there was a pain medication besides diclofenac. Um, and that's kind of why I wanted to bring this topic up, is just because I felt like it was worth talking about. There are medications called calcium channel ligands. This includes medications called gabapentin and pregabalin. These medications can lead to a little bit of CNS depression, but their main site of action is actually on the spinal cord and the specific calcium channel receptors that control pain from that diagram that I showed you earlier. Um, it's considered a controlled substance in the United States. In the United States, you also use a medication called methocarbamol or Robaxin. I should have put the generic name. I'll make sure that that's in the slides when I put this later. But methocarbamol is basically a medication that creates a sodium channel blockade, specifically in musculoskeletal tissue, and it creates a musculoskeletal relaxant effect. There's a very good amount of evidence that actually it reduces patients who have post-traumatic brain stress. So commonly we use it in trauma units, ICUs, in patients who have bad injuries post-discharge. I really tend to like it a lot on patients who are elderly who have rib fractures. It's not considered a controlled substance in the United States. There are also two other medications that I'll mention that have a lot of traction in the United States but have very little data: cyclobenzaprine and tizanidine. These medications are both commonly used for like spasmodic pain or chronic back pain. And the reason that I bring them up is just because they don't necessarily have very good evidence in terms of like treatment of actual chronic back pain. Um, there's not very good evidence to suggest their use. The one medication that does have a little bit more promise is actually baclofen, which many of you have maybe seen with cerebral palsy patients. It's used historically for spasticity, but it can also be a pretty good agent for acute pain. The medication that requires a little bit of monitoring, it's certainly an option as well, specifically for chronic pain and spasmodic pain. So these are medications that we consider multimodal pain agents. They can be helpful, but they're not necessarily first line. And their indication kind of depends on multiple patient circumstances. So a lot of people felt that there was difference between sedation and analgesia. When you give, medications like Valium, there are certain things that we could potentially do to improve our ability to do a procedure. Um, I remember reducing the elbow and giving a patient a little bit of Valium in order to basically sedate them. And the provider said, there's no analgesia in diazepam. Why are we giving them Valium? It's not necessarily meant to be something that has to be hardened through. Sedation can inflate the analgesia, and sedation can also help you do things. So sedation and analgesia is really actually dependent on why you're using the medication. So you can use fentanyl to basically induce sedation, or you can use it for analgesia. So if I use the super therapeutic dose of fentanyl, it's likely that I'm probably using it for some degree of sedation. But you also get some degree of pain control when you use that much fentanyl. So it's actually a very helpful medication in both those ways. Because a lot of patients who come in with pain end up needing to be sedated to some degree, especially patients who experience trauma. Um, when you are sedating a patient, you want to make sure that any sedative hypnotic is monitored. And the reason why is because sedation assumes CNS depression. So you want to measure mostly their respiratory status, and you want to measure that through respiratory rate or oxygen levels. Um, Not all analgesia is sedating. Not anybody who gets diclofenac needs to be on the monitor. Um, And like I mentioned before, not all sedatives provide analgesia, and that's just based off of mechanism. Propofol, barbiturates, and benzodiazepines are very good examples of this. It is important, though, to remember that, we do painful things to people, and we don't necessarily always provide them with analgesia when we do that. So a good example of this is actually intubation. When we intubate somebody, usually, the standard of care in the United States is to intubate somebody with either etomidate or ketamine. Ketamine has some degree of um, pain treatment, and it's an analgesic, but it's not necessarily like a potent analgesic. And you want to remember that intubation is painful, so it's just important to remember that pain is a cardinal sign and symptom, and although treating it like a sixth vital sign is not necessarily warranted, it is always important to remember that it's a characteristic. It's treatment, and it's something that's very, very important to the patient. This is just a discussion regarding other sedating medications. Ketamine and benzos are probably the most important one. A couple of times I am Stelliani and I've seen antipsychotics used. I've never seen this medication used before in Tanzania. And barbiturates are relatively rare, but they're gaining a lot more traction, specifically for treatment of alcohol withdrawal. Um, Most of these medications can carry some degree of analgesia. Ketamine acts on the NMDA receptor. Benzos act on the GABA receptor. Generally, any medication that acts on the GABA receptor is not going to create any analgesia. It's usually just going to be sedating. Uh, so it's not necessarily helpful in terms of treating pain if you're acting on a GABA receptor. Hmm. So I said this earlier already. The number needed to treat for pain is one, meaning that all you have to do is intend on giving one patient one medication or one possible agent, and analgesia, it works in different levels, but all you have to do is just intend on treating the pain, and the number needed to treat is really just one. Not treating pain can lead to conditions like PTSD. It can also prolong discharge and remission for patients, and it can also create or higher pain scores and less patient satisfaction. Um, so patients tend to think that clinicians care less depending on how their pain is. Um, this has been used in the United States to kind of subvert care because patients want to get opioids, and if they're drug seeking behavior, they might end up actually they might end up using that against you, and that's something that I play with my patients on a regular basis, and it's a hard game to play sometimes, but it's a game that is winnable for sure. And it's also just important to remember that people who come into the emergency department who don't necessarily have the best intentions can still have fun. Um, so I would say that pain is probably a cardinal symptom that I reevaluate more often than any other symptom. It's it complicates every dynamic patient variable. Patients commonly don't know that when you're in pain, your blood pressure goes up, your heart rate goes up, your vital signs change. It's a common thing to discuss patients that have elevated blood pressures, and it interferes with my examination. It absolutely interferes with my ability to take a good history, and sometimes it can interfere with assessment depending on how well the patient responds. So treatment of pain should always be empiric. It should always be the first thing that you're reaching for. It's always the first thing that I order when I'm taking the patient in the emergency department. Um, Regardless of whether or not it's acute or chronic pain, you want to make sure that treatment of the pain is actually the first thing that you're thinking about when you evaluate some of these patients. We get very, very bottlenecked sometimes when we're taking care of an acute complaint and we're trying to think through, what what workup should I order? But the tests are very basically, we'll talk about this more throughout the series, but testing is basically your physical exam. Your physical exam should show you about 85 to 90% of the pathology. Ordering the test is confirming that extra 10%. My pretest probability is really kind of completely dependent on my tests. And all I really need to do is do a history and exam, figure out what the patient is worried about, order pain medication, um, and order the test to try to narrow my differential. But the most important thing is to make sure that treatment is empirically treated, because that's very important to the patient. Pain is a very important symptom. So when we're talking a little bit about long-term care, you talked a little bit about this. Treatment of pain depends on whether or not it's chronic pain, relapsing pain, or remitting pain. Examples of relapsing pain would be like sickle cell crisis. Basically, worsening pain for improvement of the initial pain. Um, so sickle cell crisis would be a good example of this. Remitting pain is also a type of interval pain that occurs basically when you're having longstanding pain, it means that it really never goes away, and that you receive a flare. So examples of that um, would be things like chronic back pain. Um, I'm sorry, I mixed that up. I said relapsing pain was so relapsing pain is when you have improvement of the initial pain. It's more when it's waxing and waning. An example of that would be chronic back pain. Uh, Sickle cell would be more consistent with like a remitting pain. It doesn't matter. The point is that if patients have intermittent pain, you want to treat relapsing and remitting pain more like acute pain, um, because individuals who have relapsing or remitting pain can end up experiencing painful stimulus that is prostaglandin mediated or purely nociceptive mediated. Chronic pain, however, though, like things like fibromyalgia, um, usually carry with it some degree of comorbidity mood disorders. So usually treatment is actually multifactorial. I don't know if you guys see a lot of fibromyalgia in Tanzania. It's pretty common in the United States. Usually this type of pain is actually treated more with like multimodal pain, kind of improvement on activities of daily living, and kind of psychosocial structure that you can have for change things in terms of trying to improve their like functional capabilities, help affect questions about how can you go about this pain, how can you get how can you improve that. It's also something that I think would be worth talking about in its own lecture at some point. There is something called regional anesthesia that I think a lot of people in this discussion and group could probably benefit from. Um, I use this a lot for fractures, for nerve blocks. There are things called planar blocks where you dilute regional anesthetics, and then you create basically like planes of anesthesia. These are super helpful for like hip fractures, rib fractures. Um, there are just a lot of ways to do this, and some of them are things that I don't necessarily know how to do well myself. Um, but pain like from the trunk in the back, radicular pain, and even types of visceral pain, like types of intra-abdominal cancers are showing prominent um, good improvement with these types of procedures. It's a very vast topic, but I want you guys to know that this is something that you can do. I remember while we were in casualty at Ciliani, I did do a couple of hematoma blocks, which are usually common for like previous fractures. And those are really easy to do actually. And so you can ask your orthopedic colleague to teach you on those because those are definitely something that can improve pain scores and can actually ease a reduction technique. These types of things are, very resource dependent. And if you're talking about doing like a visceral nerve block, those are really, really intense and require some degree of monitoring and a very specialized approach. But anybody who's seeing one of these radial fracture hematoma blocks can do one, in my opinion. So they're not necessarily a crazy difficult procedure. So we can talk later about those, but it's definitely something that you want to think about too. Is can I treat this painful stimulus with lidocaine or bupivacaine? Um, it's local anesthetics, basically. There are two types of local anesthetics. I'm sure you guys remember this from med school. There are amine and ester compounds. If you're in a real pinch, all you're really acting or all you're really doing is just blocking sodium channels. So you can actually even infiltrate diphenhydramine into subcutaneous tissues, and it will actually create a similar localizing effect because diphenhydramine blocks the sodium channel. Um, there are toxicologic limits to these medications, so you always want to consider that. Usually, it's just considered that a bottle is a toxic limit, and you want to avoid using more than the entire bottle. Um, and that's just for obvious reasons because that's usually the toxicologic limit for a normal adult size patient. So don't use more than a bottle. So I've kind of hit this to a head already, but we need to make sure that pain is treated adequately. There's a higher incidence of PTSD, there's a higher incidence of chronic pain, there's a higher incidence of complex regional pain syndrome in patients who don't get adequate treatment. I don't know how often you guys see this in the literature, but there's also a good amount of data for things like sickle cell crisis and for other specific areas of acute pain that the quicker a patient gets an analgesic or even a narcotic medication, some of these studies, um, it can prevent admission and it can actually decrease their stay. This has been especially shown in sickle cell, mostly with the US population and European population. Um, but it's also important to remember that, you're not necessarily playing the game to try to actually treat the patient. You're also trying to make sure that, you're doing due diligence. And if you treat them appropriately, then you can potentially keep them out of the hospital, um, which is always a good thing because there are sick people in the hospital and you don't want them to catch those sicknesses. I've already kind of put this to a head. This is a pretty simple topic that I have a lot of thoughts and opinions on, and I'm sorry if I'm not doing the best job of actually doing those thoughts and opinions. Pain is a cardinal symptom, so in any patient who has compartment syndrome, neck crash, peritonitis, things like this, you want to make sure that you're treating their pain because their response to pain medication determines your pretest probability. If I see somebody who has a peritoneal sign and they're telling me that they have a rebound and want to palpate their abdomen, I want to make sure that I do two things: that I give them pain medication. So I'm going to give them a pain med and I'm going to reassess them. If I don't feel like my pretest probability is there enough to get a CT or to get a confirmatory test, and I feel, or the CT is not available, then the reassess portion becomes extremely important. It's pretty common for me that in patients I don't end up getting a CT scan on for, abdominal pain of any type of etiology. And I usually almost always push on their belly at least twice. And during that interval, depending on how the patient is feeling and what the patient wants, there's a pain medication in between, whatever it might be. It might be an NSAID, it might be paracetamol, it might be an opioid, um, it might be an anti-nausea medication. It doesn't really matter. It matters that you give an intervention and that you reassess, because that definitely affects your pretest probability. So um, just remember that your assessment is very much guided by the patient's response to treatment, and sometimes an outpatient you're able to do that on a long-term basis, and you're able to see somebody who comes in with hypertension and give them an antihypertensive, and then reassess their response to the medication later on in clinic. But in acute care, it's a little bit different. You're reassessing pain, you're reassessing these cardinal signs and symptoms that are suggestive of things that you would want to otherwise pick up. So um, make sure that make sure that you know pain medication is given and that you're reassessing some of these patients. So for the patient with open fracture, he was given diclofenac for pain. The part um, that I remember specifically that was a little tough was that he had such significant pain with serial examinations, i.e., casualty needed to see the fracture, and then ortho needed to see the fracture, and he had a lot of pain. It was actually one of the moments where I learned how lock and key morphine is for TransUnion doctors. Um, he ultimately went to the OR for debridement fixation. Hours later, once the operative schedule was cleared, he was discharged, and he had some routine healing from the surgery. So, a summary: um, treating pain is probably the most important part of our job. I think, at least my job working in acute care. I know that risk prevention and other things are very important through clinic. But I think that palliative pain is probably actually the primary thing that I do. In addition to talking to people, making sure that they know that there are medications and other resources to basically provide. And the medications and resources and totally understanding are completely determined of the practice environment. This is just a single scope in terms of how I practice and what I do working in the United States. I work in Tanzania and I totally understand the frustrations about not having pain medication or having specific things. If we consider it our primary role, it's our job to advocate for our patients and make sure that we have the appropriate methods of trying to um, treat anything in external. I want you guys also to know that there are procedures that are coming out that are definitely something that you can be educated on and something that you can definitely use to treat things. Um, I want you to remember that opioids it's not just my opinion, but opioids are indicated in acute severe pain. Um, it's one of the very few indications, and it's acute severe pain is something that we see very often through casualty, very often in emergency department. Um, so it's something that should be considered. Um, and I want you to also remember that chronic pain and acute pain have very different etiologies. Have, I shouldn't say very different, but very different mechanism. And their treatment is different accordingly because of their mechanism. So when a patient comes in and says they've been having abdominal pains for 2 years, it's a little bit different treatment than I've been having abdominal pain for 2 hours. I hope this was helpful. Um, the next, uh, the next thing that we'll talk about is we'll talk a little bit about chest imaging. We'll talk a little bit about CTs versus chest X-rays, and I want to talk a little bit about chests are very good topics to discuss a little bit about IV contrast. It'll be on the 27th. I say 4 p.m., so I apologize that today I said two different times. I said 3:30 and I said 4 p.m. Um, we have daylight savings here in the United States. I know that's something that Tanzania does not do, and so it threw off my ability to correlate a East African time with a American time. So that's my apologies. Um, it's we'll do it at 4 p.m. East African time. I'll make sure that that's very clear. I promise you that this link will be up, and I will share the new videos and the new lectures via YouTube, via Kopi. Dr. Nathan's very excited for this partnership, so we'll continue doing this. I promise you, we'll have this up and running by the time my my next talk goes out in December. Okay. I'm going to stop sharing the presentation and stop recording, and then we can open up for questions. Any questions or concerns right now?
Hello, everyone.
Hey, how are you?